last to last lecture. सब लोग एब्सेंट थे क्या लास्ट लेक्चर में? लास्ट टू लास्ट लेक्चर आई discussed what are the investigations. Then I started discussing one by one all the investigations. Huh? Sit down. Speak loudly so that all can hear. Tonometry. First investigation, tonometry. Second. Perimetry, no. No. Tonometry and gonioscopy, no. Perimetry, no. What is perimetry? See, you have to pay attention in the class if you are coming and then you are not paying attention. What is the point in coming and sitting here and wasting your 1 hour, and I also waste my 1 hour? Nobody is going to teach you ophthalmology after this. Okay, so you should know what is glaucoma, what investigation done, how to investigate. This much knowledge should have. But next. You want to say something?
Optic disc examination.
Very good. Optic disc evaluation. Because mostly these changes see at the in definition also it is there. How do you define glaucoma? Optic neuropathy with
elevated
without rising intraocular pressure, but with typical changes seen at the optic nerve head and corresponding defects in the visual field. And so by definition also we are saying that changes in the visual field. So if you understand definition, you will able to tell me all the things. आपने कहा IOP होना है, नहीं होना चाहिए तो टोनोमेट्री करेंगे. आपने कहा विजुअल फील्ड में चेंजेस होना चाहिए तो आप पेरीमेट्री करेंगे. फिर आपने डेफिनेशन में कहा कि देयर आर चेंजेस टिपिकल एट द ऑप्टिक नर्व हेड, सो यू सी द ऑप्टिक नर्व हेड इवैल्यूएशन. सो सिंपल. इफ यू नो द डेफिनेशन, यू नो हाउ टू इन्वेस्टिगेट. Okay, sit down. So in definition only there are 3 investigations. Okay, it's a progressive optic neuropathy. Optic neuropathy देखना है तो अब क्या करेंगे? You will see the fundus in the optic nerve head by doing fundoscopy, right? Then there are typical changes seen at the optic nerve head and with the corresponding visual field defects. So we will do perimetry to know what are the visual field defects are there or they are not there. They are because of glaucoma, they are because of neurological condition. You must have heard about hemianopias. Okay, so visual field changes can occur in many diseases, not only in glaucoma. Okay, but you should know their typical corresponding visual, but whatever defect is occurring in the retinal nerve fiber ganglion cells, corresponding to that, we should have a field defects. So perimetry will be done. Then you know that glaucoma is 2 types, open angle and closure. So what investigation will do? Gonioscopy, see the angle. It's so simple. It is so simple. If you understand what is glaucoma, then you will be able to tell me all the investigation, how to evaluate, how to confirm the diagnosis, how to follow the patients. So simple. Okay, so last time we were discussing how do you investigate a case of glaucoma, how do you evaluate a case of glaucoma, and how will you suspect a case of glaucoma. I told you it's an asymptomatic disease. It doesn't have any symptoms. So you have to diagnose. We have to diagnose glaucoma. We have to tell the patient they are suffering from glaucoma. So how will you suspect in patient glaucoma? How will you screen patients with glaucoma? With 2 important investigations. Disc evaluation and tonometry. Okay, so screening for glaucoma, you have to do tonometry, record the IOP. IOP may be on the higher side, may be normal, but with normal IOP they can be disc changes may be there, fundus changes may be there, glaucoma is optic neuropathy changes may be there. So you have to see the fundus also. So first you have to screen patients for glaucoma, then only we will be able to diagnose it. Otherwise you will miss glaucoma. So I told you initially 90% glaucoma remains undiagnosed in developing countries. 90% glaucoma remains undiagnosed. It's a disease which gives rise to irreversible blindness. Patient become blind. Okay, he doesn't know that he is becoming blind. Okay, because it's asymptomatic disease. He will come to know when the advanced changes occur when the field has constricted to this much. Tubular vision. They have tubular vision at the end. They don't realize they are losing vision because there are no symptoms. So how will you diagnose? Diagnose only on screening the patients for whatever complaint patient has come to the hospital for refraction, for any headache, okay, for eye pain, whatever complaint patient has come to the hospital, it becomes duty of the ophthalmologist to screen every patient for glaucoma. What is screen? Just order an intraocular pressure measurement and just dilate and see the fundus. This is a part of comprehensive ocular examination. Okay, so we have to do comprehensive ocular examination every patient, whatever patients come for the presbyopic correction. Okay, not able to see the near around 45 years. So we give presbyopic glasses, vision improves to 6, 6 and 6, and we send the patient back. Okay, this is what happens. okay, in a crowd of 400 and 500 OPD. No, we have to see that we have to screen every patient for glaucoma, otherwise we are missing glaucoma and patient will come when he has lost vision in one eye. Okay. So, that is what is important for you to understand what is glaucoma and why it is important to screen patients for glaucoma and how, and we suspect on basis of these two investigations. So, it can be done. We have, I told you we have non-contact tonometer which can be used for screening, very fast, can be done by technicians. So, every patient sent for vision and for IOP, then patient comes to the consultant. Okay. So, there is a non-contact tonometer which is used for screening all patients for IOP. Then patients come to us, we see patients more than 21, so we suspect could be glaucoma, so we dilate and see the fundus, and then we, if we find yes there are changes in the disc also, IOP is also borderline, or IOP is normal but there are disc changes, or there are no disc changes but this IOP is high, then we separate this patient and we tell her to undergo a detailed evaluation. This much concept you should have. Correct? Any doubt in this? So, I told you initially about tonometry. So, which is the gold standard tonometer? Which is tonometer used in patients of glaucoma. We want to accurate IOP measurement. I told you about many tonometers. I told you one tonometer which is the standard which is used in patients of glaucoma, not for screening, Goldman appellation tonometer. I told you that pictures the slit lamp mounted Goldman appellation tonometer which is the gold standard which gives the accurate readings. Okay, the Goldman, you are asked which tonometer you use, Goldman appellation tonometer. Those who are post in clinic can come and see the tonometer also, how we are recording the intraocular pressure. Okay, otherwise there are other tonometers also. Then the handheld tonometer also which can be used in pediatric patients, so patients who are bedridden cannot sit on the slit lamp. Okay, so Goldman appellation tonometer is the standard, gold standard which is used in patients with glaucoma, not for screening. Screening we use non-contact tonometer because we don't want to do any contact procedure for screening purposes. Okay, because you will be spreading infection from one patient to other. So, we do a non-contact procedure when we want to screen 500 patients, or in a camp we want to screen patients for glaucoma, we use non-contact method so that we don't spread infection. Okay. So, remember for tonometer we use Goldman appellation tonometer. Okay. Then I told you about gonioscopy. Yes, I told you about gonioscopy. Yes, last time. Yes or no? No? I think I told yes. I finished the tonometry. Then we discussed gonioscopy also. Okay, so I'll just quickly revise for you. So gonioscopy basically done to examine the angle of anterior chamber. We cannot see the angle directly with a torchlight or with slit lamp. We need to put a lens. Okay, so I told you about principle of gonioscopy, that there is a total internal reflection. We don't put this lens over the cornea. There is a total internal reflection of the rays which are coming from the angle. They are reflected back into the inside the eye. So we are not able to see the directly. So we have to put a lens over the cornea so that the rays which are coming from angle reflected, we can see the angle of anterior chamber. So gonioscope is the lens used to examine the angle of anterior chamber. Gonioscopy is the procedure. Remember this much. Okay. Now what we see in the angle? So when we have put the lens, what we are going to see in the angle? Okay. There are many types of lenses also, 2 mirror, 3 mirrors, 1 mirror means it has only one gonioscopic mirror. So we have to see angle at all 360 degree, right? So you have to rotate this 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. So you have to rotate the lens. If it is a 2 mirror lens, suppose it has 2 mirrors, then we see at a time 12 and 6 o'clock, rotate, see angle at 3 and 9 o'clock. Okay, so there are 2 mirror, 3 mirror, 4 mirror lenses are there. These are the structure which are seen in the angle of anterior chamber. I told you this. Okay, so starting from the, the angle is between the cornea and the iris, root of the iris. That is the angle. Okay, so if we start from corneal side, what you will see? End of the cornea first. That is known as the Schwalbe's line. End of Descemet's membrane, a white band. Okay, so we are seeing end of the cornea. That is a white band known as the Schwalbe's line. This is the first structure which we seen here, the white band in the angle of anterior chamber, known as Schwalbe's line. Okay. Then a pigmented band is seen in the angle, which is nothing but a trabecular meshwork. Okay. So what we see in the angle? We see 4 structures. First, starting from the corneal side, we see the Schwalbe's line, the first white band which is seen. Then comes a pigmented band, which is nothing but trabecular meshwork. A brownish pigmented band is seen, second to the white band. Then we see another white band known as sclera, part of sclera which is seen in the angle, to which the longitudinal fibers of ciliary body are attached. Okay, so we see the sclera, this is another white band. Then comes the brown band, which is nothing but ciliary body, to which the iris is attached. You know, root of the iris attached to ciliary body. Okay, iris, ciliary body, and choroid. There are 3 parts. The root of the iris attached to ciliary body. So we see part of ciliary body here, another white brown band, and then comes the root of the iris. Okay, so iris and cornea So, we see first wideband Schwalbe's line, then we see trabecular meshwork, then we see sclera spur, part of sclera which is seen as another white line, and another brownish band near the root of the iris, nothing but a ciliary body band or part of ciliary body which is seen. So, these are the 4 structures we seen in the angle of anterior chamber, and we see this in all 4 quadrants, all around 360 degrees. Okay. So, if on gonioscopy all 4 structures are visible, it means it is a wide open angle. It is a wide open angle. Okay. So, it is an open angle glaucoma or patient has an open angle, correct. Now, we grade this angle based on the number of structures seen. There may be case where no structure are visible. So, it is a very narrow angle. Patient may have an angle closure attack of glaucoma. So, we have to see all the structure. This is the gonioscopic view. Okay. This is the pupil, iris, this is cornea. Okay. So, this is the 4 structure we can see clearly. The first the brown band, the white band, and this is the ciliary body. Can this ciliary body band, this one. Okay. And this brown is nothing but a pigmented trabecular meshwork, and this white line is Schwalbe's line. This is Schwalbe's line. Okay. So, we see all the structures in the angle. So, to rotate the meshwork, the gonioscope and see the angle. So, there are many grading systems are there. The Schaeffer's grading system, the Shee's grading system. Okay. There are many grading systems are there to grade the angle. When you document your findings, you have to write what you have seen. So, their grading system is there. You have to write a grade, what grade of angle it is. Okay. So, when you document a finding, you have to write which grade is this. So, I told you grade 4 is the widest angle. Structure seen up to ciliary body band, means you are seeing all 4 structures starting on Schwalbe's line, trabecular meshwork, sclera spur, and the ciliary body band. So, it is a wide open angle. Approximately 30-45 degrees is the angle between the cornea and the iris, and it is a wide open angle. So, no chance of getting angle closure glaucoma. It is an open angle. Patient may have an open angle glaucoma. This patient, if IOP is high and you see gonioscopy, you say it is an open angle glaucoma. Then there are conditions where you may see up to the sclera spur. Okay. So, now from the iris side, ciliary body is not visible, spur is visible. So, it is a grade 3 angle, 3 structures, grade 3 angle. Still trabecular meshwork is visible, so it is still open angle. So, it is an open angle, so we call it as a wide open angle. Okay. So, grade 3 angle again open angle because up to Schwalbe's line, sclera spur it is seen. So, 3 structures are visible. Still we are able to see the trabecular meshwork from where the aqueous humor is drained. So, it still is an open angle, no chance of getting angle closure attack. Then comes the grade 2 angle where we see these 2 structures are seen only. Now, the ciliary body band is not visible, the spur is not visible, sclera is not visible. So, what we see is TM and the Schwalbe's line. Okay. So, it is a moderately narrow angle. There is risk of angle closure is there. And then comes the very narrow angle where the TM is also not visible, only the white band of the cornea is visible, Schwalbe's line. So, now meshwork is also not seen, means the iris is covering the meshwork. So, there is a chance of angle closure glaucoma is very high in these patients. So, this we label as an angle closure. Okay. So, this is a very narrow angle, risk of angle closure is very high. Okay. Suppose patient goes in a dim light, the pupil dilates, what will happen? There is a crowding at the angle, dilated pupil, they will be crowding at the angle by the iris. So, this angle will further get closed and patient will have an attack of angle closure glaucoma. Okay. Or if we put a dilating drop in the OPD without doing gonioscopy. So, what will happen? When we dilate the pupil, the iris will be covering the angle, covering at the angle, peripheral iris will be at the angle. So, this patient may have an attack of angle closure glaucoma. So, risk of closure is very high. Then there is a situation, can you see this diagram? Nothing is visible. I showed you that diagram where all structures were visible. Now, here no structures are seen. Okay. So, it is a slit angle where you see a space slit between the iris and the cornea, but no structure visible. So, it is called a slit angle, a very narrow angle. So, there is a greatest risk of angle closure glaucoma. So, here patient needs a treatment for this, because if you see this and you let the patient go, this patient may have an attack of angle closure glaucoma. Okay. So, this needs a treatment. We have to open the angle by doing a laser peripheral iodotomy. I will discuss this in detail. So, it is slit angle means there are no structures in. We put the gonioscope, nothing is visible. All 4 structures are not visible, but there is a gap between the cornea and the iris. So, it is called a slit angle, greatest risk of angle closure, and grade 0 is there is a contact between the iris and the cornea. So, it is closed. It is, you can see the contact, iridocorneal contact is visible. Correct? So, this is called a closed angle. It is a 0 angle. So, very high risk of angle closure glaucoma. So, these patients need to be kept in follow up and need management. If you let go this patient, they will come with the attacks of the angle closure glaucoma. So, now this contact can be either just a positional closure, This closure of the angle can just apposition means they are in contact with each other, or it can be a adhesion called as cynical closure. They may be adherent to each other. There is a adhesion between these two. So, there is a cynical closure. Cynical means there is adhesion between the periphery of the iris and the periphery of the cornea. It is called a cynical closure of the angle. So, when the angle is 0, we have to find out is the appositional closure means they are only in contact with each other, or their adhesions have formed there. Adhesions are formed, then it will not going to open up. Okay. So, how do we differentiate between these two? That this closed angle, 0 angle is only opposition between the cornea and the iris, or there is a adhesion between these two. So, how to differentiate this? Very important. So, we will do a indentation gonioscopy. Means you have to indent the cornea with the help of a gonioscope. Okay, known as indentation gonioscopy. Okay. So, you have to indent the cornea with the help of a gonioscope. So, what you are doing by indenting? If you indent the center of the cornea with the gonioscope, what you are doing? You are trying to push the aqueous humor in the angle. Okay. When you indent the cornea with the help of, when you are doing gonioscopy, just push the gonioscope over the cornea. So, you are indenting the cornea. So, when you indent the cornea, you are pushing the aqueous to go towards the angle, towards the periphery. So, if it is only oppositional closure, it will open up, and now you can see the structures, correct. So, you have to do indentation gonioscopy to see whether it is oppositional closure, it is a cynical closure. If the cynica is formed, then aqueous is not going to drain from here, patient definitely has an angle closure glaucoma, correct. So, you indent and try and see the structures in the angle. So, in this case, we put the pressure here with the gonioscope, so aqueous will be pushed towards the angle. So, this is going to separate these two structures, it is only oppositional closure, and aqueous can be drained. But it is a cynical closure, you will find nothing happens and they are in contact with each other, they are cynica, they are periphery. So, this patient needs a urgent management because there is no drainage, there is no passage for the aqueous humor to be drained from the trabecular meshwork. Okay. These are the various gonioscopic pictures I showed you, all 4 structures seen, okay, the white band, the brown band, white band, and this is the brown band. These are the various pictures of gonioscopy where you can see, and these are the adhesions. You can see tenting of the iris, I showed you this picture last time also. Can you see this iris tent? Here there are no cynicia, okay, but here you can see the iris tenting of the iris in the angle is adherent to the trabecular meshwork Schwalbe's line. So, once this adhesions is there and this attack, this inflammation, this remains adherent to itself. Okay. So, we can see the cynical closure of the angle, the tenting of the iris means now the iris is attached to the trabecular meshwork, it has closed the trabecular meshwork completely. So, now there will be no any drainage of the aqueous humor. So, patient will have an attack of angle closure glaucoma. Okay. So, this was about the gonioscopy. Last time I already covered this. Okay. So, now after doing tonometry and gonioscopy, now we dilate the patient, okay, because this examination needs a dilatation. Okay. So, we dilate the patient to evaluate the fundus and the optic nerve head both, because I told you in glaucoma there is a optic damage to the retinal nerve fibers, axons of the ganglion cells are damaged. The ganglion cells are die in glaucoma due to high pressure or because of other factors. So, we have to examine this area, the fundus and the optic nerve head. And I told you what is optic nerve, it is nothing but the passage of all the axons of the ganglion cells from the scleral canal to form the optic nerve. Okay. So, we are going to see changes here in this area, okay, mostly, but we have to do the detailed fundus also, because the other pathology can be there which is giving rise to the field defect which are typical of glaucoma. There may be some other fundus pathology which may be giving the field changes of glaucoma. So, we have to examine the whole fundus, not only the disc also. Too, if there are any associated other pathologies there like retinal branch vein occlusions there, retinal pigmentosa, other retinal pathology can also give rise to picture similar field defect similar to the glaucoma. So, we have to see whole fundus as well as the optic nerve head. Okay. So, we examine the optic nerve head. Now, how do we examine? Last time I told you this. How do we examine? Which instrument will use to examine the fundus in the optic nerve head? Ophthalmoscope. Which ophthalmoscope? There are 2 types, direct and indirect. So, do we use direct indirect for, is the ideal method to use, see the optic nerve head in glaucoma? Last time I told you. Okay. So, we can use direct ophthalmoscope, we can use indirect ophthalmoscope, we can use this lens also, Goldman lens also, center lens can be used to see the disc, or these are the high power spherical lenses which are used on the slit lamp for disc evaluation, known as slit lamp biomicroscopy. So, last time I told which is the ideal technique to evaluate the disc in glaucoma? This one, slit lamp biomicroscopy, means use of these lenses 90 or 78 diopter over the slit lamp, and we see a good magnified view of the disc with stereopsis with good illumination. Okay. Why we do not use direct or indirect ophthalmoscope? Because in direct ophthalmoscope we are seeing uniocularly, है ना. डायरेक्ट आपने अगर देखा हो, you have seen direct handheld direct ophthalmoscope, we see uniocularly. So there is no stereopsis. We need to see the depth of the cup also. We need to see the depth perception we want. Okay. So this is uniocular. Okay. Though magnification is good, illumination is good, but it is uniocular. So it's not the ideal technique. Indirect gives binocular. We use binocularly, both eyes open, but magnification is very less. Okay. So the picture is very small. So difficult to see the salient features of the optic neuropathy. So this is also not an ideal technique. The ideal is this, which gives all three: magnification, illumination and stereopsis. Correct? But these are, when these are used, these are used over the slit lamp. Okay, patients to sit on the slit lamp. So these two will be used in which condition? Yes, pediatric patients, patient who got sit on the slit lamp. Okay, congenital glaucoma, child born with glaucoma, or glaucoma in an early age. The patient cannot sit on the slit lamp for this ideal technique. Then we have to depend on the direct or indirect ophthalmoscope, because we want to examine the optic disc. So we will use this in, or patient who are lying down cannot sit on the slit lamp, then we use this to see the disc and the fundus examination. Okay. So this is the ideal technique. I told you, you should know what is normal first, then you will know what is the glaucomatous optic neuropathy. Okay. So disc is vertically oval, around 1.5 2.2 millimeter in size, larger in myopia. They have a long eyeball, bigger eyeball, smaller in hypermetropes. Okay. I told you what is lamina fibrosa, sieve-like structure present at the scleral canal, through the pores of which all the axons of ganglionic cells pass to form the optic nerve. So lamina fibrosa is nothing but a sheet of collagen fibers here, from which all the fibers from all over the retina, they pass through this. This is the lamina fibrosa to form the optic nerve. So through sieves of this lamina fibrosa, all the axons are passing. Okay. So changes will occur at here. Okay. Now here it is, you can see at the superior inferior pole, the pores are bigger, and is the fibers less supported by the connective tissue. At the superior inferior pole of lamina fibrosa, the pores of this sieve-like structure is bigger in size, they are less supported, and therefore in glaucoma we see mostly changes in the superior inferior pole of the optic disc. In glaucoma we see changes here and here mostly, because the fibers are less supported by the connective tissue and the pores are bigger. So what we will see in the disc? I was telling you, we see typical changes in the optic nerve head as per definition. So what do you see in the disc in the glaucoma? So how will you come to know what are the changes which are typical for glaucoma? So these are the changes which we see, 6 R's. One is the size of the scleral ring, size of the disc. Is it a large disc, it's a small disc, or an average size disc? So first we have to see, when you see the disc, it's a large disc, we are dealing with a large disc, small disc, or an average normal size disc. So first which you have to comment is what is the size of the disc? Is it a large, small, or average size disc? Second, can you see this pale part in the center of the disc? It is called cup. Okay. So what is cup? You see this pale center in the disc. So what is this? So what is cup? I told you, in disc all the nerve fibers are passing through this, the axons, retinal nerve fibers, to form the optic nerve. So these fibers are distributed at the periphery, and the center part is the leftover part, the empty part, through which we are seeing the lamina fibrosa. That is called the cup. Okay. So when the fibers are passing through the optic disc, they are distributed at the periphery of the disc. So all this center, what we see in the center, is nothing but the leftover part of the, where we see the lamina fibrosa in the center. Okay. So this is called the optic cup. So we have to see the size of the cup, because when there is a loss of fibers which are passing through this cup size will enlarge. Okay. When the fibers are passing through the optic disc and there is a damage, there is a loss of these fibers, so this is going to get thinner and the cup size will increase. Okay. So we see the ratio of the cup to disc. So how much area of the disc is occupied by this cup? Okay. Normally suppose it is 0.3, 0.4 here. It increase in size, may become 0.8, means 80% of the disc is occupied by the lamina fibrosa cup, and the fibers are only few fibers remaining which are at the periphery. So increase in size of cup is a sign of glaucoma, because loss of fibers, the axons, they die. So the cup size increases, because the leftover space will be more, because the fibers are dead now. Okay. If the healthy fibers are passing, the cup will be smaller in size. So we measure the disc to cup ratio, and there is no normal ratio, because if the disc is big, cup may be bigger in size, because more space will be left in the center. If the disc is very small in hypermetrop, then whole disc will be occupied by the fibers which are going. There is no leftover space in the center. Understand this? If a hypermetropia, disc is very small, and the fibers are same, 1.2 million axons are passing. So there is no space left. So there must be any cup. Correct? Myope disc is large, 2.5 millimeter in size. So there is more space for fibers to pass. So there will be, the cup will be larger. In center space will be more, which is left over, and fibers with their periphery. Correct? So cup may be bigger in myope, may be smaller, no cup in hypermetro, right? So there is no normal cup disc ratio. Okay, it depends on the size of. So I told you first point, comment on the size of disc first. Then comment on the cup size. The ratio of cup to disc is 0.3, 0.4, no cup, 0.2 or 0.9. 9 means the only we see the crabrosa, no fibers at the very thin rim at the periphery, because all the fibers are dead now because of glaucoma. Is it clear? Okay. So we see for the cup disc ratio, I will take this in detail again one by one. Then we see neuroretinal rim. What is NRR? Neuroretinal rim. These are the fibers which are passing. This pink area you see, these are the area between the border of the cup and the border of the disc, okay, which is nothing but the fibers which are passing. So it is called a rim. So we have to see the rim. What is the color of the rim? What is the thickness of the rim? Okay, if it becomes thinner means there is a loss of breadth of the axons is there. Okay, so we look for the rim also. Then look for any hemorrhage present here, which is a sign of ischemia going on to the in the disc. So we see presence of any hemorrhage here in the near the disc. Any superficial hemorrhage in the disc, we have to see this also. Then we see, I told you there are the fibers which are passing from the retina through this disc. So these fibers are lost, they are dead. So we will find the RNFL defect will be there here in the disc. You can see these, there is loss of fibers, so we can see that loss area here in the peripapillary area. So loss of RNFL, retinal fiber layer defect, can be seen because those fibers are dead. So now here there will be a darker area which we can see, the fiber defect we can see very well. And last we see the around the disc, there is atrophy of the retina around the disc on the peripapillary area, that is again a sign of glaucoma. So these are the 6 which we are going to signs which we are going to see at the disc, and to all these signs we need a magnified view with good stereopsis and good illumination to see all these changes. Okay, so these are the, remember, these 6 R's which are seen in glaucoma in the disc and peripapillary area, which are typical of glaucoma. Okay, so we'll take one by one. So I told you optic disc size first. I told you see large disc hai, small hai, it is a average size, normal size. Normal size is 1.5 to 2.2 millimeter, around approximately. We can measure also with the help of slit lamp, but we by experience we can tell it is normal or small or bigger. Like you can see in this picture, this is disc, this small hypermetropic disc. Is there any cup here? No, because the small disc is occupied by all the fibers which are passing through it, right? So the small disc looks more pink in color. Okay, so this is a small disc. Okay, size small, so less area for the fibers to pass. So it's a crowded disc. Looks more pink in color because fiber passing are pink in color. So look more pinkish in color. There is no empty area, left area in the center, so no cup. Okay, so hypermetro patient plus 6 diopter refractive error may have this disc. This is called a crowded disc, a very small disc with pink in color, hardly any leftover space in the center. So there is no cup, no pale area in the center. Correct? This is the average size disc where you can see a 0.3, 0.4 CD ratio. Okay, this disc, can you see this? 0.3, 0.4 disc area, rest is occupied by these are the fibers which are passing through the optic disc, and this is a large myopic disc. Okay, you can see a large cup, large leftover area in the center. Okay, they are around 0.7. Okay, so this can be, no, these are all normal discs. Okay, they are all normal discs. So if you don't know, don't comment on size of this, you may say this is as glaucomatous, you may say this is normal. Okay, this appears glaucomatous because it is a large cup. I told you a large amount of cup is a sign of loss of fibers, retinal fibers which are passing. So more bigger cup, so you may label it as a glaucomatous. You may misdiagnose glaucoma if you don't pay attention to the size of the disc. You may say this is glaucomatous. Okay, and IOP is normal, so it's a normal tension glaucoma. No, you have to see the size of the disc also. See the rim configuration of this rim also. See the color of the rim also. Then we have to diagnose or suspect glaucoma. Okay, so disc size is highly variable. Okay, depends on the ethnicity, depends on refractive error, I said, depends on the height of the patient also. So patient may have a large disc, may have a small or a average size disc. This we have to pay attention. This I already told you the 1.2 million axons pass through the optic disc. So, large disc nerve fiber distributed more peripherally. So, leftover space is large. So, there is a large cup in the normal disc also myopic disc. But small disc no cup or a small cup more pinkish in color. So, in this case if there is a loss of retinal fibers and this becomes 0.2 cup, then you may miss glaucoma in these discs because they look more pink in color. And now, in this disc if glaucoma occurs, okay, and this disc had no cup previously, now there is a loss of fibers here. So, you can see a cup here. So, you will say it is a 0.2 cup, so it is a normal, because this can be normal, 0.2 cup may be normal. So, you may miss glaucoma in these discs, you may overdiagnose glaucoma in this disc. You are getting my point? Okay. So, there is the importance of knowing the normal size of disc, normal configuration of the retinal nerve fiber layer and the neuroretinal rim. Okay. This is very, very important. So, next. Next point, first I told you about disc size. Now you understand what is the importance of disc size in glaucoma, okay? Because you may be missing glaucoma, you may overdiagnosing glaucoma if you do not pay attention to the disc size. So, first point we note always in glaucoma disc is document is it is an average size disc, or it is small disc, or it is a large disc. First we note point is this when we comment on a disc. Second, I told you cup disc ratio. What is cup? I told you it is a leftover space in the center of the disc where there are no fibers. We see lamina cribrosa, it looks pale in color. So, I told you we see more changes in the poles, upper and lower pole. So, vertical elongation of the disc is more important in glaucoma of the cup. Okay. So, this cup vertical elongation is more important because we see more changes at the poles, because I told lamina cribrosa less support at the poles. So, we see more loss of this rim and this rim in glaucoma. So, cup will elongate vertically. So, vertical cup ratio is used to assess the glaucoma. A wide range of cup is there. I told you it can be 0, it can be 0.8 depending on the disc size. How do you find out where is the margin of the cup? Where is the size of cup? So, the deviation of the, can you see this vessel is deviating from here in this picture? Okay. Here also there is a small deflection of the vessel, because the vessels are coming from here and then going out to the retina. Central retinal artery comes from the optic nerve, divides into superior inferior branches. Okay. So, from where there is a deviation of the vessel, this is the margin of the cup. So, then we calculate what is the size of the cup. It is around 0.7 cup, okay, 0.8 cup, 0.7 this is. So, we see vertical CD ratio and we find out what is the ratio of the cup to the disc, and we always see the vertical diameter because we always see change at the optic nerve head. This I already told you, large CD ratio is not always glaucomatous, okay. Small CD is not always normal, depends on the size of the disc. Large cup may be a familial trait, we have to examine the parents also. This child has come with a very large cup with a 0.8 cup. So, we may could be glaucomatous because very thin neuroretinal is left. So, it can be familial trait, we have to examine the family members also. This is very important. Next line, asymmetry of cup more than 0.2 is seen in very few percentage of normal patients. So, if this asymmetry of the cup means one disc has a 0.4, other disc has a 0.7. So, it is asymmetry. So, normally we have a symmetrical disc, symmetrical cup. So, it is asymmetry, we suspect glaucoma. So, asymmetry of the cup is we suspect glaucoma because disc is usually symmetrical in both eyes. So, cup has to be symmetrical in both eyes, except in cases where patients have unilateral high refractive error. If the disc is asymmetrical, then cup will be asymmetrical. So, disc has to be symmetrical and the cup are asymmetrical, then it will be suspect glaucoma. Okay. So, in patient, suppose patient in one eye has a high myo, one eye -8, -10. So, that disc will be large, this disc will be normal. So, there will be asymmetry of the size of the disc. So, cup will be asymmetrical, but in normally in patient who have similar disc in both eyes, cup has to be similar. If this asymmetry of cup with normal disc, then we suspect glaucoma, means this eye has a loss of fibers which has a large cup and this has a normal cup 0.3, 0.6. So, more than 2 difference is we suspect glaucoma and we evaluate the patient for further glaucoma. So, it is very important to see what are the difference in the cup size in the 2 eyes, like this eye has less cup, this eye has more cup. Okay. So, this asymmetry we suspect glaucoma because in this there may be loss of the retinal nerve fiber, because of that only the cup is bigger. This is normal cup for this patient. Okay. So, this size is normal, cup is asymmetry, suspect glaucoma, but cup disc is asymmetrical, एक में बहुत बड़ा एक में छोटा disc है, cup will be asymmetrical. Okay. So, CD ratio on its own is not significant unless we comment on the size of the disc. Okay. Vertical elongation is very characteristic, and when we follow the patient, we follow on the progression of the cup size. आज patient आया 0.4 तक, he come after 1 year, it has become 0.6, means there is a loss of nerve fibers. That's why the cup is larger. So we always follow and see there is a progression of the cup is or not there. Now I told you about third point, neuroretinal rim. So this is the neuroretinal rim. This is the cup leftover area. This is the margin of the cup, margin of the disc. So this area is called the neuroretinal rim. Okay. This is called the third point in glaucomatous disc examination, NRR. Okay. What is this area? It represents, what is this area? Nerve fibers which are passing from the disc, correct? What you are seeing here, these are the nerve fibers which are passing from the all over the retina through the disc. So what you are seeing is the healthy nerve fibers, axons of the ganglionic cells, correct? What we are seeing here, this is the leftover area, lamina fibrosa, this is the disc, and this is the NRR, nothing but the fibers which are healthy fibers which are passing through the disc. So it looks pink in color. It will never be pale in glaucoma, okay? Because these are healthy fibers which are passing. If it is pale, then it has to be a neurological disc. Ischemia हो रहा है disc को, है ना? Compressive optic neuropathy, ischemic optic neuropathy. Then it will be pale in color. So pallor is not a sign of glaucoma. If you see disc is pale, this NRR is pale in color, it means it has to be some other pathology, not glaucoma. Because these are the healthy fibers which are passing through the disc. So in glaucoma, if the fibers are lost, we see enlargement of the cup. Where this, because these fibers are dead here, but remaining fibers are healthy, so it will be pink in color. So in glaucoma, we see enlargement of the cup, but remaining NRR will always be pink in color. If this becomes pale, it has to be something else. Okay, remember this. So it has to be. So we investigate the patient. What is the cause of this? It is not glaucoma. It has to be some ischemia going on. Could be compressive neuropathy, traumatic neuropathy, ischemic neuropathy. All these give rise to cupping also, but with pallor. Okay, so we do not misdiagnose glaucoma. So it has to be pink in color. So what we see in this, we see the color, the thickness, and the contour of the NRR. These 3 points we will see in the disc, whether what is the thickness in all the quadrants, what is the color, and what is the contour of the disc. Okay. So there is a ISNT rule which says that inferior rim is the thickest. Can you see this? Inferior rim is the thickest rim, followed by superior, followed by nasal, and temporal is thinnest. This is normal. Okay. So when we examine the neuroretinal rim, what we see? We see for the ISNT rule. So what is ISNT rule? There is a difference in thickness in the fibers at the optic disc. So inferior is the thickest. Can you see this looking thicker? If you see, this is the NRR from here to here. This is thicker. This is second, then nasal, and then temporal. It's called the ISNT rule, followed in about 83% of eyes. Okay. So when we examine this NRR and we see what is the difference in thickness of these two. If the superior inferior becomes equal to superior, it means there is a loss of fibers. Okay, this is thicker now normally. So if now this becomes equal to this, that means there is a loss of fibers here, and there is an enlargement of cup here. You will see a notch here. It means there is a loss of fibers in the inferior pole. So this ratio, superior to inferior is inferior is more than superior, nasal is more than thicker than temporal. So inferior to temporal is 2:1, inferior to temporal is 2:1. So because this rim becomes equal to temporal, it means there is a loss of rim. So we have to examine the NRR, see is there any change in ISNT ratio, is this rim is thinner. Okay. So we examine the NRR for thickness first. Whether the suppose the inferior is thicker and it becomes thinner than the superior, it means there is a loss of fibers here. So there is a thinning at the inferior pole, and we see corresponding changes in the field also. It's called the polar notching. This thinning here. Okay. So we can see there is a, can you see there is no rim here, it's a 0.9, almost whole disc is occupied by the cup. Okay, this is a gradual increase in the ratio of the, this is 0.3, 0.5, 0.7, 0.9. So it's increasing with time, means patient is progressively losing his nerve fibers. Okay. So we have to see for the any polar thinning or polar notching or excavations there in the disc, then that is a sign of glaucoma. Suppose their fibers are lost here, so you will find a cup like this. Okay, these are the rim is lost here because the fibers are dead now. So we will find, you will find this is the cup which is a notch here. So this rim has become thinner compared to this. Normally inferior is thicker than superior. So we have to look for this. Can you see this in diagram? There is a notch here, vertical elongation of the cup, with there is a inferior notch here. Okay, and their nerve fiber layer defect is also seen here. Can you see here again? It is a thinning of the nerve, the an NRR, and there is a acute angulation of the blood vessel also. So, this is the how do you see the NRR for the focal loss or concentric loss. And then I told you about the color also. It is always pink in color in glaucoma. Pallor is not a sign of glaucoma. Okay. If it is pale, except in angle closure glaucoma where there is acute rise of pressure to say 60, 70, then there may be stream out of the disc, there may be pallor of the disc may be there. So, except in angle closure glaucoma acute attack, in glaucoma we do not find a pallor of the optic disc, it is a sign of some other cause. So, significant pallor, then cupping suggests a possible neurological cause. So, disc is pale, this disc is pale in color, can you see NRI is also pale. So, this is not a glaucomatous disc, this is glaucomatous because remaining NRR is pink in color. Okay. So, we differentiate between glaucoma and neurological disc, okay, because we may be over-diagnosing glaucoma unless putting patient on anti-glaucoma drugs. So, we have to diagnose glaucoma based on this detailed evaluation of the disc. Next I told you about hemorrhage, fourth sign hemorrhage at the disc. Can you see this splinter hemorrhage at the disc? This is the hemorrhage at the disc. Okay. This is called a trans hemorrhage which is seen at the border of the optic disc. It is a sign of ischemia going on to the disc, seen in normal tension glaucoma. I told normal tension glaucoma IOP is normal, the vascular theory which holds true in normal tension glaucoma. I told there are two theories of optic neuropathy, one is mechanical, other is vascular. Why do you see changes of optic neuropathy? Either mechanical pressure at the lamina cribrosa because of high tension glaucoma, high pressure. So, second I told you vascular theory where there is a vascular dysregulation is there, the blood flow to the disc. So, there is a hypoxia at the optic disc resulting in death of the ganglionic cells. So, here this hemorrhage is a sign of ischemia, decreased perfusion of the optic disc. Okay. So, this is present, the splinter hemorrhage, trans hemorrhage, it is a sign of normal tension glaucoma. It is a prognostic sign, indicates there is an ongoing ischemia is going on in the disc. So, we have to further escalate the treatment. So, presence of hemorrhage at the disc indicates there is a ischemia, there is a disease progressing, there is a decreased perfusion at the optic disc, commonly seen in normal tension glaucoma because their vascular theory holds true. Okay. So, this is an important sign. If we see, then we increase our treatment, we further lower down the IOP, correct. Then comes the advanced glaucoma. Can you see this picture? There is no rim. The whole disc is occupied by this, all lamina cribrosa. You can see the pores of the lamina cribrosa. This whole disc is occupied by the lamina cribrosa. Hardly there is any rim present here. Can you see the change in the course of the vessel here? Okay, this one. These are the vessels are just at the periphery, and there is no healthy fibers left. So, it is an advanced glaucomatous optic atrophy. Okay, patient has no vision at all in this disc. Okay, this is advanced glaucoma where patient has completely lost his ganglionic cells or axons of the ganglionic cells, retinal fibers. The whole disc is now nothing but lamina cribrosa. All the pores are empty. There is no fibers passing through it, and there is hardly any rim left. Can you see this? There is no rim at all. Okay, this is a picture of an advanced glaucomatous optic atrophy. Okay, so if we do not follow the patient, patient does not come, then this is the picture at the end where patient loses his vision completely. The fifth sign I told you, the fibers which are coming from all around passing through this, these fibers are lost, these are axons. Okay, so can you see this wedge shaped defect, this one? These are the normally fibers pass through all this. So, when the fibers are lost, we see a darker area because there are no fibers. We see more brighter vessels because vessels are normally embedded in these nerve fibers. Okay. Now, this fibers is lost, this is dead fiber. So, we see a darker area here with the prominent vessels compared to surrounding area. Okay. So, the nerve fiber layer defect are seen like this, a wedge shaped defect fanning out from the disc and vessels appear more brighter, and here there will be thinning of the neural rim also. So, this is called a nerve fiber layer defect sign, which the fan out defects are seen. This is a red field photograph of the fundus. Okay. So, this is red field photograph where we better appreciate the RNFL defects. So, this is how we see the wedge shaped defect and seen at the superior inferior pole more common, and we see at the same point we see the thinning of the neural rim. Okay. This is the picture of the glaucomatous optic neuropathy, vertical elongation of the cup. Can you see the vertical cup elongated? This NRR is very thin here, and we see the corresponding RNFL defect also, better appreciated in red field photograph. The fifth sign of glaucomatous optic neuropathy. Okay. So, what is happening is these fibers are becoming dead and they are passing from here making the NRR. So, NRR thinning, vertical elongation of the cup with the RNFL defect with presence of a hemorrhage at the disc. These are all signs of glaucomatous optic neuropathy which you have to see very carefully, okay? So, not to miss glaucoma. Okay. coming to the next sign, that is the parapapillary atrophy. I told you around the disc also there are some changes which we see, because atrophy of these fibers which are passing, we see some changes around the disc in the peripapillary area known as parapapillary atrophy. So, it is called alpha zone and beta zone. The beta zone is one which is near the disc. There is a damage to the retina here also. So, loss of choriocapillaries with RP resulting in seeing the sclera visible here at the disc. This is also a sign of damage to the retina due to high pressure. So, parapapillary atrophy beta zone, again it is a sign of glaucoma, and this also increases with the advance in glaucoma. This area will increase, okay, this parapapillary atrophy. So, beta zone is again because of vascular insufficiency. So, there is a loss of choriocapillaries RP. So, we sclera is seen with the large vessels around the optic disc, known as beta zone, which is typical for glaucoma again. Okay. And last is the vascular changes, which is now because of this loss of neuroretinal rim, the change in the pattern of the vessels which are passing from the optic disc. Normally the vessels come from the optic disc and they are or the surface of the fibers, and then divide into superior inferior branches. Okay. So, these fibers which are coming. Now, when the fibers are lost, we see bayoneting sign, sharp turn of vessel at the rim, because the supporting fibers have lost now, they are dead. So, there will be sharp turning of the vessel. Can you see this turning of the vessel here? So, this is called a bayonet, this is the bayoneting sign. It is again a sign there is a loss of the rim here. So, vessels are bending when they are coming from the optic disc, the sharp bend of the vessel at the disc margin. Known as bayoneting sign is again a sign of loss of the axons and nerve fibers at the optic disc. So, this is an indirect sign of the loss of fibers. So, sharp bend when vessels are travelling from the disc to the surface, this sharp bend known as bayoneting sign. Okay. So, we see some vascular signs also at the disc which indicate there is a loss of the axons. This is called this is a vessel known as circumlinear vessel which runs at the margin of the cup. Now, the cup has receded here. So, we see a bearing of this vessel. Okay. Cup margin which was here previously, now it has gone here. So, we see bearing of this vessel which was running at the cup margin known as circumlinear vessel. So, bearing of the vessel, bayoneting sign, these are sign of the loss of the fibers, and these are typical. These sign also tell us there is a loss of fibers in this area, the retinal nerve fibers. Okay. So, again just to revise, what are these changes of optic neuropathy, glaucomatous optic neuropathy. I told you first see the size of the disc. Okay. I told you what is the importance of the size of disc, because large disc may have a large cup, glaucoma may be misdiagnosed. A small disc may have a small cup or no cup, more pink in color, so you may be missing glaucoma in this disc. So, when you are commenting on the cup, it is important to comment on the size of the disc, very important. I told you ratio of the cup to disc. Okay. The cup will enlarge at the as the glaucoma progresses because loss of the fibers. So, we have to see the cup to disc ratio in relation to size of the disc, correct. Then I told you about NRR, see the color, any notching, contour is lost, or there is a thinning, or there is a change in the color is always important, because pallor is not a sign of glaucoma, it is a sign of neurological disc. Then look for a splinter hemorrhage at the disc which indicates there is a ischemia going on at the disc. So, we have to further escalate the treatment because there is a progression, it indicates a glaucoma is further progressing. So, we have to increase the step up the treatment. I told you RNFL defects which are wedge-shaped defect typically seen in the parapapillary area. So, we see those defects, it means there is a first sign of glaucomatous optic neuropathy. We may see these signs later, but this is the first sign of glaucomatous optic neuropathy, the loss of RNFL, because these fibers are coming and they are lost. So, we see a darker area in the retina around the disc. So, we have to see red field photograph to see this, then area of atrophy around the optic disc and the typical vascular changes, the bayoneting sign and bearing of the circumlinear vessels. So, I will take the perimetry of field of vision in the next class. Okay. So, we are going to revise all these changes in the next class. I am going to ask you. Okay. So, go and read. Jivit, come. So, go and read, come here. So, go and read, you will go and read, you will read tonometry, you will read gonioscopy, you will read the disc changes, then you will be able to understand it. Okay. So, next time I am going to revise all this, then we will start with the perimetry or the visual field examination.